Good day, everyone. Today is What, When, Where Wednesday. What does that mean for you? Well, today you will get an NCLEX question of the day. And today we're going to look at pharmacology. Pharmacology. All right, specifically, we're going to look at a glycopeptide antibiotic class. All right, now you may have not heard about a glycopeptide antibiotic class, but you are probably familiar with the word vancomycin. Vancomycin. It has mycin at the end, and so when I think about mycins, I think about gentamicin, amikacin, streptomycin. A lot of those have that mycin on the end. But there is a difference. Sometimes we think that vancomycin is an aminoglycoside because gentamicin, aminocacin, streptomycin, all those amikacin, all those are part of this aminoglycoside. And even I have been guilty of saying, yeah, Vanc, it's a mycin, it's an aminoglycoside. But actually, it is a antibiotic class all of its own, but very similar in the toxic effects it can have on the body. So, vancomycin belongs to the glycopeptide antibiotic class. It is distinct from aminoglycosides. Both classes of antibiotics are used to treat bacterial infections, and they have different mechanisms of action, and they do target different types of bacteria. So that's what makes them a little bit different. Now, the aminoglycosides, they work by inhibiting bacterial protein synthesis. They are effective against certain gram-negative bacteria. But in contrast, vancomycin primarily targets gram-positive bacteria by interfering with cell wall synthesis. All right, so what are we talking about? Vancomycin. When is it used? Commonly, it is used to treat MRSA. All right, used to treat MRSA. Um, where we see it commonly in the hospital setting. You usually want to give it into a very good strong IV. I don't like running vancomycin in a peripheral because it can be very harsh on the veins. So what, when, where Wednesday? This is going to be a good one. So you're going to have a question of the day. We're talking about vancomycin, commonly used to treat MRSA, some other gram-positive bacteria. Again, it works by inhibiting cell wall synthesis in bacteria, and it is effective against a wide range of infections. Also, with vancomycin, we're going to look at a slide that talks about how it can cause red man syndrome. So, if you've ever heard about that, that's another what. What is red man syndrome? When can it occur? Um, where, in what situations, what can cause it, what can increase the risk for it, and then what can we do as a nurse to decrease the risk of that happening. And then some other things that we need to think about with vancomycin: peak and trough levels, kidney function, all those things. So you're going to enjoy the What, When, Where Wednesday NCLEX question of the day today. Stay tuned, get your pen, get your paper out, take your notes, see if you could get this question correct. And I hope to see you next time. I hope you enjoy the video. Thank you. All right, next question. So we looked at that outline, and sometimes we may have to assess lab results or make sure that we're not giving a med if it's contraindicated for a reason. So in this question, the nurse is preparing to administer the next dose of prescribed Vanc. All right, and this patient's getting Vanc because they're being treated for sepsis. And our query is, which of the following lab results would be the priority? So we want to know which of these lab results is most important for us to review, and it may be the first one you really need to look at. And at what point is she giving the medicine? She's preparing to administer the next dose of vancomycin. All right, so we got our query, and we know our time proximity is right in the beginning. She's getting ready to give it. Should we check the peak serum drug level? Are we keeping that one or letting it go? All right, so keep that one out. Yep, very good. Yeah, someone's already said it's C. Yes. Very good. All right. Keeping, some says keep it, possibly the peak serum drug level. Okay. So we got some good choices. We made, so some are saying no, some said keep it. So we'll keep it just so we can clinical reason. So focus on your clinical reasoning. It sounds like peak serum drug level is something we would check periodically. We usually check a peak and we check troughs with vancomycin. Peak is after the drug administration. That's a very good point. So she's preparing to give it. If we look at the peak is really telling us how high that level of medication is at after the drug is already given. So that would have been the previous dose. After the previous dose, that's the highest point it got to, which usually we check a peak about an hour, 2 hours after when the drug can peak in the bloodstream. So it's possible, but keep in mind that she is preparing to give it, and this is before, right? She's getting ready to give the vancomycin. This isn't after. So that's a very good point. If you're thinking that peak is after, that may not be the right time proximity. That may not be the right time frame. All right. Vanc can affect the kidney. Yes, it is nephrotoxic. Nephrotoxic. Hepatotoxic is liver. All right. So if we keep that, how about serum potassium? Is that a lab that could be checked or should be checked before giving vancomycin? Are we keeping it, throwing it out, getting rid of it? No. Yeah. Very good. Yeah, potassium really doesn't affect vancomycin. And if you do the general rule for antibiotics, the two things you're looking at is liver, kidneys, or other toxicities. Antibiotics can cause toxicities, ototoxicity, liver toxicity. All right, so could be, but no. Yeah, could be. Very seldom you'll see where potassium can be affected. But remember amphotericin B, that was a good one. Amphotericin B can affect the potassium level. It can make the patient hypotensive. So there are, there may be some. That's one I can think of right away is amphotericin B could make you hypokalemic. So could be, but generally not with vancomycin. All right, good, good. So liver and kidney. Some people are saying liver and kidney could be creatinine. So serum creatinine, are we going to keep that one? Creatinine. Yeah, a lot of people are saying kidney and ear toxicity could be caused by vancomycin. So serum creatinine. All right, we'll keep that. Very good. Yeah, so that's creatinine levels, checking your kidney function. And is that something we want to do before we give that vanc? If they're already having problems with their kidneys, vancomycin is really going to make it even worse. Very good. All right, we got one more to eliminate or either keep. Hopefully, we can eliminate white blood cell count. Do we want to review that before we give this medication? White blood cell count prior to administering. Yeah, no. So, white blood cell, although they have an infection, whether that white blood cell count is high, because yeah, I agree, it is going to be high if we're still treating sepsis. It wouldn't depend on whether or not we're going to still give that medicine. If it's high, it's probably expected because they're in sepsis. If it's coming down or decreasing or in normal range, depending on how long they've been on the drug, that tells me it's working. So I need to keep giving it as prescribed. All right, so we can get rid of white blood cell count because it really won't help us determine whether or not it really isn't a priority before we give the med. But I would be watching that white blood cell count to see if it's working. Is there white blood cell count going back down to normal? Is it increasing? Then that might mean it's not treating the infection appropriately. All right, so we got down to A or C. Should we check the peak serum drug level or the serum creatinine level? So we had one that was talking about kidneys and one that was talking about the drug level itself when it actually peaks. So go back to your facts, think about at what time frame are we doing our assessment? Are we following the lab results. The priority for the nurse to review when prior, right? This is preparing to administer the next dose. Creatinine, yes. That creatinine is going to be most important prior. Very good. Creatinine. Awesome, awesome, awesome. So the difference in the two, the main thing is knowing that peak is checked after you give the drug. It's not something we check before. What do we check before we give the drug? What do we call that drug level? Can anybody remember? Before we give the medicine. Yeah, draw the trough. That's it, TAP. Check the trough 30 minutes before. Yes. So we would check the trough before we give the medicine. And a lot of times they'll say go ahead and give it. So we usually check it about half an hour before. So the trough is the lowest level that that drug is concentration wise in the bloodstream in the body before the next dose of medications due. So we want to see where it is. Was the body able to clear the drug out? It should be very low, and that usually happens for any drug, because remember, all meds have to go through the liver, filter it out, and get it sent to the kidneys to be excreted. If the kidneys were not able to excrete vancomycin very well, that trough level is going to be high. So I think I might have, did I spell it wrong? TROGH. Yep, that's right. So if it's too high, oh, let me turn this down, then we may have to hold the medication, but many times we won't hold it. They'll just go ahead and give it and then adjust the next dose. So a lot of times they don't want you to wait until you get the test results. Unless the patient already has kidney problems, then I might wait, but we just have to keep in mind it can put the medication behind an hour if I wait, and it's fine. So I always check with pharmacy to see, should I wait, or I'll go ahead and look. So another good way to look at this is if you go ahead and look at the serum creatinine and you see that their creatinine has been okay, they should be able to get rid of that medication. Their trough should be pretty reasonable. So you can go ahead and give it. And then once they get those results, pharmacy will adjust the dosage. But if I looked at that serum creatinine and I noticed there's been trending up, then I may get with them and say, it's going to take an hour for me to get results. So I don't want the medicine to be behind, but I don't want to give something that's going to further damage their kidneys. And they may say, go ahead and just wait until we get the trough and we'll readjust the times. So we were looking at what benefits the patient versus the risk of readjusting it over an hour or two. Very good. You guys did great with that. So with pharmacokinetics, just remember, majority of meds, if they're asking about adverse effect or what am I going to check on the medication, a lot of times it's kidney related or liver related. You'll probably find, and it just depends on what it is, but I find that a lot of meds are nephrotoxic more so than hepatotoxic, but it just depends on the medication. So think about metabolism, how different developmental stages metabolize medications differently. So if we look at our elderly or our infants, they're at highest risk. They may not be able to get rid of that drug out of their body that quick, that soon. So if they're saying they're giving a medication to an elderly, my first thought is, well, how's that going to affect their body? Is it a very strong toxic med? Some meds are bound to fat in the body, and some meds are bound to protein. So they mentioned warfarin. That's why we have to keep a tabs on a Coumadin or warfarin, the INR level, to make sure they don't develop a toxicity. They can bleed out. So we also have to think about the route we're giving it. IV is going to be very fast, and our motility, GI motility. What drugs can be given on an empty stomach versus those that should be given with food because they could cause nausea. How fast that med can be absorbed, and is it okay to have an acidic environment? Um, Most meds, absorption is going to be decreased if the environment is not acidic. So I keep that in mind. But there's also specific meds like tetracycline, that's going to be one of your number one drugs that if food is in the stomach, then the absorption is decreased significantly. So they tell you no food, no milk with tetracycline, no food with levothyroxine, because that's one that we have to have a good level of. And those are oral meds that we give orally. So they're highly affected in the GI tract. All right. So if you couldn't remember things on vancomycin, then I would write down that I need to check that trough before 30 minutes before and usually it's the third dose because they're going to wait until they've got a couple doses in and they'll start monitoring those levels. And we talked about that's the lowest level just before they get the medicine. Vanc is nephrotoxic. It can cause nephritis. We're going to monitor their serum. The peak is drawn an hour after. So it wasn't really needed. We don't really need to check the peak before we give a medication because that was after the last dose. They drew that an hour after the administering the last dose. Um, we don't want to hold doses. So we talked about that. The priority is going to be checking that serum creatinine. And then our white blood cell count is going to help assess how well the infection is being treated. Is the antibiotic working? One other thing with this is a little song, the Rudolph the Red-Nosed Reindeer. With vancomycin, it can cause red man syndrome. So we have to run it very slow. We run it about 90 minutes, about an hour and a half. Sometimes, depending on how high the dose is, they may run it over 2 hours. So it just depends on the dose, depends on their kidney level and their kidney function. So they can look like they're red. That's an adverse effect.